let's go ahead and get started talking about analysis. I know I've got kind of a couple of tough sessions today because you all are starving, maybe. I know I am. And after lunch, I have to keep you all awake. So we're in this together. You know, my goal right now is this first hour for Intro to Analysis is to make sure I get you out on time so you can all go eat. Oops. All right, so here are the objectives for the Intro to Analysis presentation for today. Basically, we're going to be focusing on device-associated infections, specifically CAUTI and CLABSI, and we will talk about some of the methods behind the statistical measures that we use for these event types. But I am going to just give you a little upfront that while we will go into some of those methods, just know NHSN does those calculations for you. So, you know, don't be frightened if you see all of it. We really just want to give you some background information as to how these are calculated so that you're more knowledgeable when you speak to the data. So I'll show you some pieces of how to apply the NHSN analysis functions in NHSN to some real world examples, or as real as we can get at CDC. And I'll also show you how various metrics from NHSN can be interpreted and used to drive prevention of those HAIs. So really our focus, we're going to be talking about basics of using the results and mostly discussion on the types of data you can obtain rather than all of the technical steps. I think it's certainly valuable to go through a demonstration of using the NHSN application. However, that works best when you all can do that with me, and we're not able to do that today. So we do have documentation online about how to do all of that. So I'd rather focus our time today on actually interpreting and using the data. So on our website, this is new as of last year sometime, I think in the spring, we added a patient safety analysis resources page. And on there, you can, we have all of our codes up there, like a data dictionary. So if you're a group user from a state health department or a QIO, you may be interested in looking at how some of the variables are defined and how the algorithms work. But we also have on there a link to our analysis quick reference guides. This is a library of short documents that are specifically directed towards performing certain tasks in NHSN analysis. We gave you a lot of them in your resource book for those who are in the room today, but for those who are watching online, they're available on our website. We tried to organize these by some of the frequently requested reports and also some of the output option types. And we tried to keep these to 1 or 2 pages. Sometimes we had to go longer than that, but they're really meant to direct you towards that specific task. So if you're looking at how do I get a single SIR for my entire fiscal year, we have a guide that will tell you to do that. And my colleague and I are constantly updating this website, trying to add more quick reference guides based on the questions that we receive from you all. So we certainly appreciate your help in letting us know how we can help you. And this is just an example of one of the quick reference guides. We have one specifically targeted at how to analyze MBI, LCBI, CLABSI data in NHSN. If you're looking to see what CLABSIs were considered MBIs. So if you've seen any of my analysis presentations before, you've seen this slide. And I always think it's important to remind everybody of why we analyze data, specifically analyzing data within NHSN. And really it's because, you know, as Dr. Cardo mentioned this morning, there are a lot of different groups who are using your data. Okay, not only are you submitting these data into NHSN for use for yourself, but also for CDC, for state health departments, CMS. You may be part of prevention initiatives, or your hospital may be part of a larger corporation that is gaining access to these data. But at the end of the day, these are your data. They belong to your hospital. You spend a lot of time performing the surveillance to get those data. And so analyzing these data within NHSN can give you information about how your hospital is performing. You can look at these data over time to see, how are we doing with our prevention efforts? Are there any gaps that we need to take care of? And it also helps you to be knowledgeable of what's going on before someone from your administration comes up and says, hey, I got this report from the health department or from whomever, and it says that our SIR is high, and we don't want you to be taken by surprise. So we want you to be able to see the same data that other groups may be using. So before we can analyze and obtain data from NHSN, we have to do this step called generating data sets. And it's something that is a really quick step for most folks. However, it can be often confusing. So I always want to explain what's going on with generating data sets. So basically, every single user in NHSN, every single person who has their own identity to log into the system has the ability to analyze data. Well, most of them do, depending on their user rights. And what we do is we say, okay, if you're going to analyze data, you need to do this step called generating data sets, which means we will take a snapshot of the NHSN database for all the data reported to NHSN for your hospital. We're going to take a snapshot of it for that moment in time and take all those data and organize them into certain buckets. So your CLABSI rate level data are going to be separate from your SSI, SIR data, which are going to be separate from your lab ID event Linelist type data. So that way, when you're ready to run a report, things move much quicker. I will show you a screenshot of how of the screen in the application, how that works. But just know that we do this also to make sure that you're working with a copy of your data and not the live database, okay? So you don't have to worry about breaking anything. Everything is just a copy. So just a reminder, because we're taking a snapshot of those data, when you generate data sets, your data sets are frozen in that moment in time. So if you're running reports and you notice something is wrong, like, oh, I forgot to enter 1 month's worth of data, I have to go back and enter it. After you enter those data or make any updates, you have to generate data sets again. Otherwise, your reports will not be reflective of the most recent changes. So this is what the screen looks like. We did change this last year, I think in the summer. So basically the default now is that when we generate data sets, we generate for the last 3 full calendar years up through today's date. So if I were to generate data sets today, it would include data for my hospital all the way back to actually January of 2011. This is an old screenshot, but it would be January 2011 all the way through today's date. If you're a hospital that has been reporting to NHSN for a long time and you need to do some complicated or in-depth analyses of trending data, then there's a box that you can check that says include all data reported to NHSN for this component, and it will include everything since you've been reporting to the NHSN. Okay, so there's a button that says Generate New. You click that button, there you'll see a progress bar. And for most hospitals, I think it should take probably less than 5 minutes or so. But for groups like state health departments and QIOs, it could take longer because there's a lot of data that we're trying to compile for you. So now let's talk about some of the basics of the analysis output options. So after data sets are generated, you're ready to analyze your data, and they will be current as of when you generated data sets. There's really no lag time besides waiting for that process to complete. We refer to reports as output options, and I'll likely use those terms interchangeably today, so I'm just giving you the heads up. I don't mean to confuse you, but I tend to like to use the word reports when I can. And we organize all of these into what we call a tree view, and I'll show you what that looks like. And really, we do this to help guide you towards the data you're actually interested in analyzing. Okay. I am frozen up here. All right, here we go. Okay, so this is a screenshot. To get to this page, you go to analysis and then output options, and we organize everything by module first. And then you might be able to see it looks like a little folder, like a file folder. So if you click on that folder, it will open up to the events that are included within that module. So for device-associated module, that would include CLABSIs, VAP, VAE, CAUTIs. And as you expand those, we have all of the output options that we have kind of pre-formulated for you. These are kind of default options and settings that we have set. So you can click Run next to any one of those to get the predefined report for you. It will include all data that are included in your analysis data, or in your analysis data set. So if I were to click Run on that rate table for CLABSI, ICU Other, it would give me monthly rates going back to January of 2011 for every one of my locations. And by clicking Modify, you can, of course, modify the report and the data that are included in that report. So one of the other things that we have are called CMS Reports. So how many of you are familiar with the CMS Reports folder? Okay, quite a bit of you. That's great. So really, when we created this folder and these reports, what we said is we want to provide hospitals with a way to look at their data that will be submitted to CMS on their behalf. We want a mirror so that if they run that report and something is missing, that's a clue that it's going to be wrong when it's sent to CMS. If you run one of these SIRs and you get no results, guess what? Nothing will be sent to CMS on your behalf. So we created all of these specialized reports for each event type and for the CMS reporting program. Right now, they're under the Advanced Output Options folder in NHSN. And so this is just a little plug for me to tell you, don't be afraid of that advanced folder. There's a lot of stuff that is in the other output options folders in there, and we'll talk about some of them over the next couple of days. But the number of reports that we have to include here are growing because the CMS is expanding their quality reporting program requirements for HAI data. And so this summer, what we're going to do is we're going to take that CMS reports folder and we're going to take it out of advanced. We're going to move it so it's its own main folder and then create subfolders that are applicable to each quality reporting program and your facility type. So if you're an acute care hospital, you're going to have your own folder with what is now 5 SIRs that you'll need. So it'll make it a little bit easier to find your way through, especially as we know for like LTACs and IRFs, you kind of have to dig into this list to find what you need, and the list is only going to get longer. Okay. So I'm going to briefly describe some of the basic analysis output options we have. I think everybody here is familiar with the concept of a line list, and in NHSN, it's really no different. It provides a detailed record level review of all of your data. It can be really helpful in identifying any trends or identifying any data quality or accuracy issues, and it is the most customizable report that you can get from NHSN. Just a tip for some small hospitals, or really for anybody, if you want to do this, it's a little bit of a time saver. Within that advanced folder, we have something called event level data, and the first option is a line listing for all infection events. So if you need to look at, or if you're interested in looking at, you know what, I want to look at all my CLABSIs and CAUTIs and SSIs and VAs. I want everything in one list. You can get that from the event level data folder within Advanced. That's also the option to use if you need to include pathogen level information that are entered for each of your infection events. Frequency tables, I feel, is one of the most underutilized report that could probably be the most helpful or the biggest time saver for you as you're looking into your data. Frequency tables basically provide you with a count of records that meet certain criteria. So in this screenshot, we actually have a 2x2 table of the specific type of CAUTI event, whether it's a booty or SUDI, by quarter. Okay, so if you need to know how many of these were booties out of all that I reported, this will actually give you the count. So you don't have to go through and manually count through a line list. You know, another example to use this could be, you know, what is the distribution of ASA score for each of our colon procedures? If you're looking to make sure that maybe data were reported correctly, if you're importing data for the first time, you want to make sure everything's good, make sure that there aren't any default values used. This frequency table can really help you with some of those counts. And my colleague Lindsay tomorrow will be talking about how to use this to look at your CDI specific data and the onset and CDI assays. So we do have, of course, a quick reference guide about how to use the frequency table. So I urge you all to start using it if you have not already. It can really provide a lot of helpful information and help supplement the other reports that you're using. We also have bar charts and pie charts. These are not exportable, meaning that you can't export these into, let's say, an Excel document. So they just show up in your web browser, and they will give you just counts of data. They are not, they're not graphically representing any rates or ratios, okay? Rate tables, of course, we're going to spend some time talking about that this morning. And these will give you your facilities calculated rates and device utilization ratios where appropriate, and also the NHSN pooled means that we have published and the comparison of your facilities data to the NHSN data. When those data are available. We don't have pooled means for everything quite yet. What I do want to tell you is that a description of all of these rates can be found in the event-specific chapters within the NHSN manual. So this could be incredibly helpful, especially if you're looking at lab ID rates or if you're looking at VAE rates and you're not quite sure what's included or excluded from those. The manual can help you. There's a data analysis section in each one of those. Run charts, these will allow you to graph rates and device utilization ratios over time. We do not have these available for SIRs as of yet. You can include the NHSN pooled mean or another defined reference line if you have a separate goal that you're looking to obtain. And you can run these by month, by quarter. And again, these will only produce in like your browser window. So you can't take this and export it into Excel. And then finally, standardized infection ratios or SIRs. Hopefully we've become a little bit more comfortable with these SIRs over the past couple of years. These are a risk-adjusted summary measure. We will be talking about SIRs as they relate to device-associated infections this afternoon. And we do have some details in the SIR newsletter, and I'm not going to go into too much detail about that now. I do want to highlight some new analyses that we added in 2013 and 2014 this year. So we do have various output options for ventilator-associated events. We have the line list and the rate tables. One of the questions we've been getting quite a bit with regard to VAE is, where are the VAE SIRs? Where are the VAE NHSN pooled means. Where's the benchmark? And the answer is we don't have that yet. It's a brand new event, so we can't create benchmarks or SIRs for data that we hadn't collected before. So once we're sure that we have a sufficient amount of data, we can begin to analyze at CDC and determine how we're going to represent those data. We also have variables for distinguishing MBI LCBIs from all other CLABSIs. We'll talk about that this morning. The new NHSN annual report of device-associated rates that was published in December, for the first time, we included rates that were specific to critical access hospitals. It's actually something that we had gotten a lot of questions about from our critical access hospital members, and they wanted to know, are my rates included with all the other acute care hospitals? And so we decided, you know what, let's take a look. We didn't have enough data prior to that, prior to last year, to be able to look at it. Well, now we had enough data. We had enough critical access hospitals reporting to us. And what we saw was that they were significantly different from all other acute care hospitals. And so we now have rates that are stratified by all critical care areas combined for these hospital types and all non-critical care areas combined. We also do have SIRs for MRSA bacteremia and CDI, and variables for distinguishing procedures with a closure method other than primary, and we'll discuss those tomorrow. So I have like 3 short general tips for analyzing data in NHSN. One is to read the footnotes in your reports that you get from us, especially SIRs and rate tables. You'd be surprised at the information that's in there that can answer some of your questions that you may have, including the date that you last generated data sets, okay? Also, generate data sets regularly so that the data are up to date, and we especially recommend this to generate data sets and run your reports as close as possible to that quarterly CMS deadline. And to keep a copy of that report so that you know what to expect that will be submitted and you're not taken by surprise in case anything had changed. Also, review data for accuracy and completeness. I'm going to briefly go through these sections of what we call the design modification screen. So this is actually the screen that appears when you click modify next to any one of our output options. I say I'm going to go through this briefly just because we have the documentation in our quick reference guides online that describe all of these elements. So the top section of the modification screen is the same for all of your output options, and it allows you to modify the output characteristics. So the output name, the title, the format. What I do want to point out here is that we have this output name. I know it's kind of hard to see on the screenshot. So, you know, one of the great things about these output options is that if you modify them, you can actually save your changes. You can save it as a template so that if you're going to be running this similar report for different time periods, you don't have to go through and modify everything again. However, we strongly recommend that you change the output name when you create a new template, because if you save multiple output options with the exact same name, not only is it going to be difficult for you to find the exact report that you need, but it can also end up, what we've learned, causing a problem in the application. So we are actually going to be preventing this in many cases, preventing you from saving more than one output option with the same name. But really, it will make it a lot easier on you to make it specific to what you need. Also, the default output format for all of our output options is HTML. That really means that it opens up in a browser window, a pop-up. So you have to make sure your browser allows pop-ups from cdc.gov. The middle section of the modification screen is also the same for all of the output options, and you can specify the data that will be considered. So this is where you can get really detailed and crafty with limiting your data or filtering out your data for what you're actually interested in looking at. If you're interested in a certain time period, certain procedure categories, certain locations, this can all be done through this middle section of the modification screen. And we do have quick reference guides related to each one of these mini sections here on this screenshot. So, we recommend looking at that. I think, again, that for those in the room, they're in your quick reference guides that we've provided. And I will say that using that grid for the specify other selection criteria can take a little bit getting used to. So, just experiment with it a little bit. But if you need some help, just send us an email. And the bottom section of the modification screen actually is different depending on the type of report that you're running. So you have different options for a line list, which will allow you to sort the line list. And then you have a completely different option for rates and SIRs, which is only to look at how the SIRs will be grouped. So do you want one per month, per quarter, per year? So just to reiterate, all the options can be modified to meet your needs, and you can save them as templates. We have a quick reference guide on how to do that, and we refer to these as custom output options. And it will be a big time saver for you if you're running the same reports on a regular basis. All right, let's get into some of these real-world examples. The first one is, let's say you want a line list of all CLABSIs that your facility has reported to us for the calendar year of 2013, so January through December. You want to sort the list by the event date, and additionally, you would like to include information on which CLABSIs met the MBI-LCBI definition. So I wanted to provide a little note for you right now about MBI. So those CLABSIs that are identified as MBI-LCBI are currently included in CLABSI rates and SIRs, including for the CMS reporting, okay? So these have not been split out yet. It was optional to identify these in 2013. It's now required to identify these as MBIs, and they had been part of the CLABSI definition prior to that time. So those baseline data that we're using for SIRs presumably include those that would have met an MBI-LCBI definition. So they are currently included, but once we have at least one full year of reporting using this definition, we can determine how these events should be handled in future measures. I think we have a pretty good idea, but we don't want to make a final determination until we can actually dig in and look at those data. Okay, with example number one, and this is just a heads up to you, if you're interested in looking at what are the criteria we used to identify these MBI LCBIs. Let's say you're interested in knowing which one of those three criteria were used. You can add these variable names to your line list. All of the criteria, when you enter an event into NHSN, you have to match the algorithm and the definition. You have to put in and check the boxes for all the criteria. So those variables and those criteria are available to you in the line list. They all begin with CR_. Those are our criteria variables, and these are the ones specific to MBI data. So in order to look at these data, the line list we used is a standard CDC report. We went to device-associated module, then we went to the CLABSI folder and went to the first option, line listing for all CLAB events. And so we modified this, and you'll see the results. I'm not going to show you every single modification we made, but this is our resulting line list. So there's a couple of things here that I do want to point out. First of all, we do have this sorted by event date. But notice that we calculated some variables for you in case you're interested in looking at any trends. So we have an age on event date that you can look at. We have the number of days from admission to event date. So those can be helpful to you and in looking at any trends in your hospital. We also have a variable called location type, and this basically groups your locations into some major types like critical care. So if you're interested in looking at a report of all of your ICUs, let's say you're a fairly large hospital with a lot of ICU locations, you don't want to have to go into our modification screen and be like, okay, I'm going to have to select like 5, 6, 7 different locations to include. Instead, you can use something called location type, and CC means critical care. So by doing location type equal to CC, you'll get only all your ICUs. And here's a variable, MBI LCBI, that will be an indicator to you as to whether or not that CLABSI met the MBI LCBI definition. All right, so let's get into some exciting stuff. I really like the rates and the SIRs. So right now, actually, probably many of you are starting to hit this annual report time, trying to summarize 2013 data if you're running on a calendar year. So let's say we actually need a CAUTI rate report for the entire year of 2013 for 4 of our ICU locations. We want to look specifically at these 4. So you are expected to compare each location's rates and device utilization ratios to the national data. So device-associated rates, many of you may be familiar with this. They are calculated as incidence density rates, or IDRs. And you may see IDR when you run your rate table in NHSN. Well, what exactly is an incidence density rate? Well, the numerator of an incidence density rate is the number of new cases during a period of time. So that's our incidence. We're only looking at newly defined cases. And the denominator is actually the person time during that same period of time. So we're looking at the amount of time at which people were exposed or at risk for a certain infection. We do use a multiplier to aid with the interpretation. So I'm going to quiz you guys now. Do you all have the remotes are handed out, right? You guys got them? Okay, so what measure of person time is used in the calculation of CAUTI rates in NHSN? 1, patient days. 2, catheter insertions. 3, patient admissions. Or 4, catheter days. Voting is open, and actually, I don't know if this is enabled. Here we go. All right, it's counting down. You can't see it, unfortunately, but we've got 5 seconds to vote. I don't think it worked. Okay, so for some reason it didn't work, but the answer is catheter days. So we use this for CAUTI rates because we're interested in looking at the number of people or the amount of time during which people were at risk for that specific type of device-associated infection. So we're looking at the number of device days. Okay, if this were a CLABSI rate, we'd be looking at central line days. Okay, so we calculate our rates by the number of CAUTIs divided by the number of urinary catheter days times 1,000. And that 1,000 multiplier is to aid in that interpretation so that we can interpret it as per 1,000 device days. All right, so here's another good question for you. How are device-associated rates presented by NHSN? Combined device-associated rates by location, meaning CLABSI, CAUTI, all rolled up into one. Overall by the facility, by individual location for each device-associated event type, or overall by location acuity level. So one rate for all of your ICUs combined, one rate for all of your wards combined. And the polling is open, but it's not taking it. It's closed. Okay. All right. So the rates are actually presented by individual location for each device-associated event type. How many of you have been asked for an overall rate ever? Just Yep, a lot of you. Okay. And, I'll show you later on why we don't do that, why we don't provide an overall rate for all locations, because, the rates and the types of patients can really impact the risk of infection. Okay, so why do we do this? We do this because for us in NHSN, location serves as an indicator of like populations for the patients that are receiving care in that location. So earlier, Kathy mentioned that, you want to make sure that you are mapping your locations correctly in NHSN, because if you incorrectly map those locations, you're being compared to a benchmark that is not appropriate for the types of patients that that are receiving care. So you could look too high or too low. And we want you to get the best accurate depiction of your data. Like populations are believed to have similar risks for healthcare-associated infections because they may have similar medical devices, similar invasive procedures, or similar host factors that may affect their susceptibility. So, of course, as I mentioned earlier, we do these calculations for you, and we provide CAUTI rates and DU ratios by location. This screenshot is pointing out our rate table for CAU data for ICU, other, /SCA/ONC. So basically everything except for NICU data. And NICU, CAUTI reporting for NICU locations is optional. It's not a protocol event, so you can't do it in plan, but some folks are doing that voluntarily. What I want to let you know here, and this would be applied to rates and SIRs. For rates, we actually, by default, give you a rate per month, okay? And it's really good to look at your data by month because you can get more on time and more timely a depiction of your data as they're being entered. However, when you're running an annual report, you want a rate for the year for all of your ICUs. So at the bottom of our modification screen, we have a little group by option, and in that drop down, you can select Summary YR. That will be one rate per location for a calendar year. And of course, we do not provide overall rates that combine locations. So here's an example of our output. This is a table that has actually part of our output. We'll expand it a little bit later on, but it has the rates for all 4 of our ICU locations that we were specifically interested in for the calendar year of 2013. Okay, so here's another question. I'm hoping this will work. It's not working. Is anybody hitting a button? Are you guys all playing a joke on me? Are you guys all just... So the question is, and we've kind of answered this, how would you... Oh, you're going to exit out? Okay. No, that's okay. We can fix it later. Okay. Thank you. So how would you interpret the MICU's CAUTI rate of 1.827? Is it 1.8 per 1,000 catheter days, 1.8%? 1.8 per 1,000 patient days, or 1.8 times higher than the national? And just shout out, what do you guys think? Number 1, all right, you are correct. Oh, it did take some votes. What do you know? All right, that's great. Okay, so the answer was 1.8 per 1,000 catheter days. So when we run the rate tables, and what I've done here is I've just kind of taken out one location, the medical ICU, because it's a little bit easier and less busy for us to work through. So when you get the data out of NHSN in a report, we actually have columns in white and columns in yellow. In here, we've kind of got columns in nothing in blue, and columns in white. So all of the data on the left-hand side, I've notated as our hospital's data. So it's our infections that we identified, our catheter days, and our rate. But the columns in white are the NHSN published data and comparisons, okay? And we provide you with that pooled mean, a p-value, and a percentile. So, this is something that I realized that we hadn't done in most of our analysis presentations before, and I think it's really important that you guys get a little bit of an understanding of where our pooled mean comes from. Like, what on earth are they doing there at CDC when they publish this report? And I can tell you that it's not just press a button and out comes the data like magic. It actually requires quite a bit of time for us to run through, clean up any data, look for anything that may be incorrect, and make some comparisons. So the pooled mean that you get out of our rate tables in the output option actually come from the published annual data summary, what we've called the annual report. It's actually a device-associated rate report now. And this pooled mean is not an average, okay? A lot of times when we hear the word mean, we think of an average where you're taking, okay, how many were identified divided by how many people actually reported those data? What's their average rate? Instead, we use a weighted mean that pools the data within that strata. So in this report, I've actually pointed out a burn critical care unit. We have 38 locations that reported in this screenshot. And what we end up doing is we actually take the number of CAUTI that were reported to us, so 148, and we divide that by the number of urinary catheter days that were reported. So 148 CAUTIs came from 38 locations, and over 36,000 catheter days came from those 38 locations. And when we multiply that by 1,000, that's how we get our pooled mean of 4.1. Okay. So, if you've looked at our report, we have pooled means for different types of locations. But why do we have some pooled means that are stratified further than location? So we do have some ICUs for which we also look at the medical school affiliation for the hospital. And for medical surgical ICUs that are not major teaching, we also look at that location's bed size. And, we're asked, well, why is that? Well, not only do we try and find the best ways to risk stratify these data, but when we look at something like, let's say, a major teaching institution with a medical ICU versus a medical ICU that's in any other type of hospital, not only do we see that the pooled means may be statistically significantly different, so we run some statistical tests to see is their rate any different from the other rate, but we also compare the percentile distributions that we provide in the report and the median. Okay, so we look at ways to see what is really going on here. In some of these locations, their pooled mean may actually be the same. But when you look at the percentile distributions, the 10th percentile, the 90th percentile between those two are vastly different. And so we're like, there's something going on here that is making the experience in these types of hospitals different for the same type of ICU. So we give more weight to those comparisons. Okay, we get this question a lot. How do I know which published report NHSN is using to make comparisons? Well, for one, we include it in the footnote. There's that footnote I was telling you. It can answer a lot of helpful questions. So we include the reference to the published report that we're using for that pooled mean, okay? But also, on our website, we have a list of aggregate data sources for the rates and the SIRs, and each one of those links up to the report that we're using as a reference, okay? So this is available on the Patient Safety Analysis Resources website. I believe it's towards the bottom. The direct link is here. And, we update this anytime we have to update the aggregate data in NHSN, which right now is happening just for rates. So every year we will update this document. Okay. So with our rate table, we have what's called a p-value. I know many of you are probably familiar with this. Well, we need to answer, what is this p-value? What is actually going on here? Many of you may already know, okay, well, I know that if it's less than 0.05, something is significant, but I really don't know what it all stands for. Well, the p-value is actually a probability, and it helps us determine rarity. In other words, how rare is this outcome that it could not have happened by chance alone? In other words, are we really seeing a difference between these two rates or between these two populations? Or is it just by chance that we notice a higher rate and there's not really something going on? Oftentimes in the literature, a p-value of 0.05 is considered the convenient cut point to use. And so we use that at CDC for our reports, our annual reports. So if the p-value is less than 0.05, then we can say that we see a significant difference. Otherwise, if it's greater than 0.05, then we say there is no difference. And that is related to statistical evidence, and that's what that's focused on. So when we provide the p-value in your output, what are we comparing? Well, we're actually comparing your facility's rate by location to the NHSN pooled mean for that same location type. Okay, so again, this pooled mean comes from that published report. It's not a live pooled mean. Look at everybody entering data today. It's what was published, and we compare your hospital to that number. Okay, so we have another voting question. I'm keeping my fingers crossed it will work. Based on the data in our table, is our county rate significantly different from the NHSN pooled mean? So we could say yes, based on the p-value, no, based on the p-value, or yes, based on practical significance, which is actually something we will be discussing tomorrow, is practical significance. All right, so it looks like the votes are coming in. This is great. This is working. I'm going to put a timer up. Am I getting a timer? No, there we go. 9 seconds left. All right, let's see how you did. All right, so 88% of you said number 2. And you would be correct. The answer is no, based on the p-value. And why? Because the p-value is greater than 0.05. Our p-value is actually 0.2347. So we would say that our rate is not significantly different from the pooled mean. Okay, so going on to our next question here. How would you interpret the percentile for the medical ICU, the percentile that's in this table? Would you say 47% of medical ICUs contributing to the pooled mean had a rate equal to ours, 47% had a rate lower than our rate, or 47% had a rate higher than our rate? Okay. All right, I'm going to turn on the timer. We got 8 seconds left. All right. So let's see. 16%, number 1, said that 47% of hospitals had, or ICUs, had a rate equal to. 57% had a rate lower than, and 27% had a rate higher than. So what is the correct answer? It is number 2, okay? So if for those in the room, when you get back home and you take a look at the rate report, you could see the distribution. It goes from 10%, which is going to be those that had the lowest rates, all the way up to a 90%, which indicates those that had the outlier high rates. So 47% is actually looking at where you sit on that distribution, and you can say 47% of hospitals that reported data to the annual report that contributed to that pooled mean for that location had a rate that is lower than your rate. So this is this is a screenshot from the report of the pooled mean with the percentile distribution. So you can see here that for medical major teaching, our pooled mean, or our percentile distributions went from 0.4 all the way up to 5.5. Okay, and also this is a good point for me to demonstrate to you. Notice when we look at medical major teaching and medical all other ICUs, now their pooled means are pretty different. We have a 2.9 and a 1.7, but look at how their percentile distributions differ and vary. Okay, so that just kind of helps illustrate why we split these out the way we do, is because the experience is different in these locations, especially compared to even burn ICUs. That's why we don't lump everything together. Okay, so the percentile distributions that we provide allow you to see where you fall compared to those who contributed to the pooled mean. So again, it's not looking at where do you sit compared to everybody else today. It's where do you sit compared to the data that were published. And looking at these percentile distributions, they can also help you in setting goals that are different than the pooled mean. If you are saying, you know what, the pooled mean is not good enough, we want to shoot for a lower rate for our ICUs, you can look at the percentile distributions for each one and try to set goals based on that. We also provide device utilizations for you in the rate tables within NHSN. These can be used to complement your rates when you are interpreting them and reporting them out. So we look at the proportion of days in which patients were at risk for that infection. We calculate this as the number of device days divided by the number of patient days. So similar to device-associated rates, we compare your location's ratio to the pooled mean, and we also provide you with the p-value and the percentile. All right, so we have another question for you, question number 6. How would you interpret the results? The DU ratio in the medical ICU is significantly different than the NHSN pooled mean based on statistical evidence. The DU ratio is not significantly lower than the NHSN pooled mean, or compared to the NHSN pooled mean, we would not consider our device utilization ratio actionable. So the voting is open. See the responses coming in. All right, you've got 10 seconds left to vote. All right, so let's see how you did. All right, so an overwhelming number of people, I can't really see the percentage, but a lot of you, said number 1, that our DU ratio in the MICU is significantly different than the NHSN pooled mean based on statistical evidence. And that is correct. That's the answer I gave. However, this is a point where, you know, it could be up to interpretation because you could use statistical evidence, and that's going to be used quite a bit. It's used probably for most of the decisions that you're making. But you may look at your device utilization and say, well, 0.66 compared to 0.70, is that really that much lower? I mean, our statistical evidence is saying it is, but maybe that's not good enough for us. Maybe we want to try and shoot to get that down. Maybe we want to look at those percentile distributions and you know, maybe based on that, you would consider it actionable. Okay, so this is something, you know, I've recently added this year with my presentations, and it's the elements of an interpretation. And many of you are probably already interpreting your data with multiple elements, and you're not just relying on just a number. So, you know, first we cover the basics with our interpretation. How many HAIs? What's our rate and device utilization ratio in this case? Over what period of time? Okay, that's something NHSN that we give you. You look at the period of time, we're going to give you this information. You can interpret the statistical results, such as the p-value, the percentile. Those aid in your interpretation. But then there's other elements of your story. We don't just stop with the numbers that we give you. There's other information that you have that we may not necessarily have in the NHSN database because it's not information we collect. So you may want to look at what locations experienced 0 HAIs. You know, do you want to start celebrating some success in those areas. Looking at trends, have rates gone up? Have they gone down in any location compared to a previous time period? Do you want to look at the 6 months prior, the year prior? If you're setting a goal that's different than the pooled mean, how is the progress towards that goal? Are you reaching it, or are you going in the opposite direction? And we can keep going, okay? Keep supplementing the data that we provide you with the reports. What were the organisms identified? Are you noticing any trends? Are there any prevention efforts started during this time period? Have there been any changes in staff or types of patients receiving care in the unit? Do you maybe need to map this to a different CDC location when you report these data to NHSN? And even, has education of NHSN definitions enhanced your surveillance and understanding of definitions? Are you realizing that, oh, you know what, I may have reported that differently before, and now I have better education, so we may notice a little bit shift in our rates because we've fine-tuned our surveillance. And then looking ahead, what are our plans to lower rates or maintain low rates? So I've provided you all with an example interpretation. I'm not going to go through each of these bullets, but it's basically, this example is running through the numbers. How would you interpret just the numbers that are provided on the rate table? Same, here we had the rates. Now we can go into the device utilization. You add that to your interpretation. But then we can take it a step further, okay? So what I've added here is that, and this is something we didn't focus on earlier, but we have now 4 of our ICUs up here with their pooled means and our p-values and everything. So we can say, while not statistically significant, there is concern over the high CAUTI rate in our cardiothoracic ICU. An additional investigation may be necessary because our rate is 2.4. Compared to the pooled mean of 1.8. All of our device utilization ratios are significantly lower than the pooled means. All of our p-values are less than 0.05. However, our medical ICU is not much lower than the pooled mean, okay? We have 0.66 compared to 0.7. So, maybe we want to focus a little bit more on that location, on that unit. But also, internal comparisons over time would give us additional information on improvement in our CAUTI incidence within our facility, okay? So comparing yourself to yourself, okay? That is sometimes the best measure of success. So this isn't a voting question. I added this because guess what? It's just about lunchtime. And I know you've all been asked this before. So if your hospital administration says provide a single overall rate for your hospital's CAUTI experience, what's your response? Sure. Or, you're kidding, right? Or a single rate would not be risk adjusted. However, I'm happy to provide an SIR, which I know you all are. Or silence. You pause looking for the nearest exit. So this is basically going to segue us into your dessert today, which is the SIR for device-associated infections.